Hi, I want to welcome you all to our COVID-19 Road to Recovery webinar. Today we'll start our discussion with the dramatic shift in hospital and specifically pharmacy financial performance during this ongoing pandemic. We'll also provide some cost management strategies that are crucial to current and future pharmacy operations. I'm Pam Andrus, and I want to serve as the moderator today for this discussion. The webinar is scheduled to last approximately 40 minutes with Q&A immediately following. All participants will be on mute, so please type in your questions and we'll answer them at the conclusion of the presentation. For more information on CompleteRx and to subscribe to our monthly newsletter, please visit the CompleteRx.com website. Let's go ahead and get started by introducing our speakers. Mark Brown has been a pharmacist for over 25 years and leads the business development team for CompleteRx. In his 25 years of experience with hospital pharmacy, it includes both operations and business development in a variety of hospitals and hospital-related partnerships. His experience and understanding of operations gives him the unique ability to understand and create healthy solutions with specific hospital environments. Next is our Chief Operating Officer, Dr. Rick Burnett. Rick leads the day-to-day operations for all CompleteRx customers. His 25 years plus experience in hospital pharmacy includes experience in a variety of settings from small rural locations all the way to multi-system academic settings. He's an active member of the American Society of Health System Pharmacists, appointed twice to serve on the ASHP Strategic Advisory Board for Leadership Development, and Rick is also a member of the American College of Healthcare Executives. And I'll now turn it over to Mark and Rick.
Okay, thank you, Pam, and thanks to all of you for joining us, either good morning or good afternoon. What we want to do today is kind of talk globally about really what's going on in American hospitals today, given the current environment we're in with the COVID-19 pandemic. Talk about the impact it's having on hospitals and healthcare in general, America's health, and then look particularly at the second largest departmental cost in every hospital, the pharmacy. And what we hope you take away today is that, there's no doubt COVID-19 has put us in a particularly difficult spot, and is probably the greatest healthcare challenge that we've seen in the last century. But we want to understand what the market's experiencing and how pharmacy departments are going to be called on and need to respond to mitigate that. We also want to demonstrate the imperative supporting that of having a methodical and sustainable cost management program within your pharmacy. And we really want to talk about and understand how you measure what matters. In other words, the data-driven foundation of what a cost management program should contain or look like. So in other words, what are the most impactful and manageable data sets and resources that every pharmacy should be doing on a daily basis. And then lastly, again, recognizing that COVID-19 is a huge crisis right now, we want to understand that we've all seen many different things over the years that have impacted expense and revenue to hospitals, and pharmacy has been called on to mitigate that time and time again. So the point is that this should be an everyday program and not just COVID related. So if we move on to, let's talk about what's actually going on, and everything that I'm going to mention has either been published and or I've spoken directly to many CEOs in many states, and this is what they're telling me is going on. And realizing that, the disease, the virus is a moving target. There are some takeaways that are critical for us to understand. So again, it is a national emergency that's changed our world and continues to be one of the greatest healthcare disruptors that we've seen, both from a clinical and a financial perspective. So facts are that nationally, Since the beginning of the pandemic, hospital census has been reported as being reduced by roughly 46%. So therefore, 46% or more of their top line revenue has gone away. Outpatient surgeries and other outpatient care, as we all know, have been eliminated temporarily. They've come back, and then many times in many states, the surge has caused them to be limited again. Frankly, for most hospitals, this is a very difficult pill to swallow because those procedures typically account for approximately 75% of the hospital's entire top-line revenue. So again, inpatient revenue declines and outpatient revenue declines of monstrous results. So the other thing is that about 50% of ED visits nationally are not happening, so that's declined. And in short, we've heard it from many people, and you hear it on the street, Americans are avoiding hospitals and health care, which presents even more downstream risks in terms of health in America. So if people are having serious disease, strokes, heart attacks, whatever, and they're not going for fear of contracting COVID-19, it's going to be something that continues to plague us for a while. And then as a result of all that, it's safe to say that in general, hospital budgets are just broken. And many hospitals have really uncertain financial futures. So due to these and other factors, the AMA actually published a white paper a couple of months ago that stated that they projected that American hospitals for 4 months, March to June, and this continues, possibly will lose about $200 billion with a B in revenue over the 4 months, or $50 billion per month. On top of that, just last month, Moody's Investors Service found that and stated that nonprofit hospitals should expect to see negative financial results into next year, 2021, and the federal assistance program that has come out thus far is not even close to fully compensating those losses. So CEOs and hospital administration teams have been asked to mitigate the financial crisis, and for the most part, they have taken on the top two non-departmental expenses, which is always going to be labor and overhead, or G&A. So your accounting, your marketing departments, etc. And we've seen that in almost every hospital. We've seen and read and heard about massive furloughs, RIFs, et cetera, reduction in anything to reduce expense on their balance sheet. And then we've seen that hospitals have that haven't done this. It does have some negative downstream impact with lack of both personnel or PPE when the COVID cases do come back. So this forces hospitals to absorb inflated registry labor costs and or inflated supply costs. So at this point, it's imperative, and CEOs are talking to us about looking at every departmental expense and kind of zero basing that to see what's necessary and put programs in place and make decisions that will right their ship holistically. Again, the two largest departmental expenses are always in hospitals are always materials and supplies and pharmacy. The hospital's financial sustainability is a real national crisis right now. going forward, and therefore it's even more important that we all understand what's going on and implement systems that will deliver a quality pharmacy service at an affordable cost. So with that said, it's pretty clear that COVID-19 is a challenge that requires an all hands on deck response. This slide depicts three possible scenarios of the COVID-19 spread and what they may look like. Dr. Anthony Fauci of the CDC has stated that there's virtually no possibility that the virus is just going to disappear, and it's been repeatedly stated that this pandemic is in the hands of the American public and our social response. But I would also add that healthcare is in the hands of the response of healthcare professionals, including the pharmacy, especially the pharmacy. So we really can't, while these are scenarios possible, because of not a clear understanding of what the virus is going to do and what people are going to do, et cetera, it's really impossible to make a clear prediction. But it is safe to say that we're going to battle this for some time, and we're going to win if we do the right thing. So moving on, I want to turn this over to Rick, with that said, and have him talk about some of the specific challenges in the pharmacy departments that we're seeing, and how Complete RX has worked with our partners to set up programs to mitigate and contain costs. Rick?
So thanks, Mark. So, Mark had talked previously, what was going on in the hospitals in general. So I want to focus a little bit on, what was going on specifically in the pharmacy, what were some of the trends that we were identifying, and then get into, what can we go ahead and do about it. So, while people were stocking up on toilet paper, pharmacies were stocking up on drugs. And early on in the pandemic, there was a lot of confusion about what to do. Very early on, I would say January and February, everybody was told to keep calm. And then when March hit, the floodgates kind of opened, and everybody, started getting prepped because the disease started to become reality for everybody. One thing that we looked at is what was going on with the different drugs being used to go ahead and treat COVID. So we ran an analysis of about 50 different drugs that were used to treat COVID just to see what was going on with purchases. And what we found out with this is that we saw about a 30% increase in these agents over prior years. And these drugs were primarily things like antibiotics, vasopressors, the things that you use to sedate patients in the ICU. And the patterns were kind of scattered across the country, and a lot of that was just dependent on availability and if you could get the product. If the product was available, people were buying up on it and trying to get whatever they want. So there really wasn't any one particular drug over the other that was seeing a big increase. We also wanted to take a look at, what was going on with regular treatments. Mark had mentioned that a lot of people were staying away from the hospital, so we want to kind of do an analysis and see what was going on with, life or death or critical medication. So then we did a bit of an analysis on anti-neoplastics. And what we found here is that anti-neoplastic drug spend increased about 14.9% from prior period, but those year-to-year increases were in line with what we had seen with past years. So, but the biggest challenge we were seeing with anti-neoplastics is that the volumes appeared to be steady, but the challenge we were having in the pharmacy is that there was a significant shortage of PPE. A lot of the hospitals were diverting their PPE from their materials management and giving it to the frontline providers, but PPE is also needed by the pharmacies to be able to compound these sterile products. So it wasn't so much a challenge here of getting the anti-neoplastic drugs. The challenge here was getting the PPE so you can make the products. So essentially what you had on the pharmacy on the expense side here with the drugs is you were seeing an increase in drug expense at a time when hospitals were seeing a decrease in revenues. So the next part of the pharmacy picture was to evaluate what was going on with our labor. So, initially, hospitals outside of really hot zones like New York and Massachusetts, Detroit, and Chicago, we really didn't see too much change in what was going on with labor. Hospitals at that time were trying to figure out what they were going to do and trying to put together their planning. But as the virus began to spread, we started to see hospitals starting to implement their surge plans. And then what we saw there was a significant uptick in overtime. What tends to happen in pharmacy is typically in a pharmacy, they do not have the FTE numbers that other departments, say, for example, like nursing might have. So, for example, if you have a hospital that has 10 FTEs in your pharmacy and 2 are out either because they're in quarantine or you've implemented a furlough, that's 20% of the staff gone. But that doesn't mean a lot of the work goes away. Like I mentioned before, anti-neoplastics, the volumes seem to remain steady. Those are very time-consuming, labor-consuming products to be able to compound and distribute up to the floor, so somebody had to do that work. So what we saw was increases in, a lot of the overtime. And on a higher level with hospitals, a lot of them implemented furlough plans. So what we saw is that pharmacists and technicians were being required to take vacation time or PTO to be able to make up for the hours lost due to the furloughs. So that was taking those expenses off the balance sheet, but once again, because the work was still there, we're still seeing some overtime happening on here. So, your question is, now that we know that we've got, a lot of expenses going out the door and our revenues are going down, what is it that we need to do to get our second highest expense in the hospital to get our costs in line? And what I'm going to tell you is going to be very basic here, but essentially it's going to be the key to your current success and your future success. What I found is that demanding that your pharmacy department cut your expenses by X amount every time there is a financial crisis in the hospital typically doesn't work unless you've got significant waste in your system. And if you do have significant waste in your system, that means you've got bigger problems. Essentially what's going to happen is if you're going to be successful is you need a sustainable pharmacy cost management program. Just like every year you've got a process for doing your budgets, or you've got a process for doing your performance reviews with your staff every year, it's no different in pharmacy. You should have a sustainable process to be managing your drug costs. The chart I have up on the screen right now is a modified version of a capability maturity model. So in a capability maturity model, on the low end of the spectrum, typically what you have are a lot of ad hoc processes. And when you get to the right side of the model, what you have there is sustainable processes where you're always looking to try to get better. So for a lot of hospitals, they're in that novice zone. And in a novice zone, a place that really doesn't have a focus on cost containment, what you do is you have a crisis, for example, like COVID-19, and you make decisions across the board that we got to cut X costs, and then pharmacy goes ahead and scrambles to see where they can reduce their cost. Typically what I find in situations like this is what the pharmacy will do is just go ahead and try to burn off their inventory. They just say, okay, we got to quit buying, burn off some inventory, and what you'll find out is you'll get a short-term gain in that it looks like your costs have gone down for the month, but eventually you're going to have to book that inventory adjustment on your books, and then that inventory value eventually, when the microscope is off the pharmacy, tends to go up. Ideally, where you want to be operating is on that expert zone. And in that expert zone, what you're doing is you're constantly looking at your drug purchases, you're identifying cost savings, you're monitoring the progress of those cost savings being implemented, and then you're looking for what's coming down the corner so you can plan, and be prepared to address that. I would say based off of my experience, the majority of hospitals are probably operating in that functional or intermediary zone. At a minimum, you probably want to be at that advanced zone. Getting to the expert zone is desired, but a lot of your limitations is going to be on your data gathering capabilities and the resources that you have on site to be able to identify those savings opportunities. So that's the model, and that's where we want to be. So your first step in this process is you got to follow the money. To address pharmacy expense, you need to know where you're spending your money and who is spending your money for you. As Mark mentioned before, in pharmacy, the equation's a little bit flipped. In a lot of departments, labor is the big expense, and then your supplies are your second largest expense. In pharmacy, typically in your budget, drugs account for 70% of your expense. Your labor is about 28%, and then 2% is your other. That's your supplies and your other equipment and some of your leases and things like that. So, your primary place that you do want to focus is on the drugs and then labor. On the other side of the coin, you also want to look at where you're going to generate your revenue. In a hospital, you can generate significant amount of revenues on the inpatient side, but for the most part, you're capitated in what you're going to get reimbursed. Whereas outpatient billings and outpatient continues to grow, that's really why you want to focus your efforts if you're looking at places to maximize your revenues, because you've got J codes and you get actual dollars back for those products. So it's kind of like that old Willie Sutton rule, go where the money's at. The same thing you want to do with pharmacy. Very basic premise, but oftentimes forgotten. So the first thing I want to talk about is, how do you go ahead and what should you be looking at when you do monitor your drug spend? So trying to manage your drug costs without consistent reviews of your purchase data is really going to limit your ability to be successful. At a minimum, when you're looking at your drug costs, you should be looking at 3 key reports every month. And the first one is looking at your total drug cost compared to your budget variances for the month. The next is looking at your drug cost by therapeutic category, and then looking at your top drug. And when you look at your top drug, you shouldn't be looking at a line item. You should be combining all doses for a particular drug product and sorting from top down. And all those measures, you should be adjusting those for pharmacy adjusted patient day. I know a lot of institutions use adjusted discharges or adjusted patient days or CMI adjusted patient day, but based off the experience, pharmacy adjusted patient day seems to be more relative in regards to what's going on in the pharmacy. You can have a discharge adjusted for CMI, but it doesn't necessarily take into account the intensity, for example, of like an anti-neoplastic product, where that would be the case if you're looking at pharmacy adjusted patient days. So that's a recommendation. And what you're looking for here initially up front is you're looking for any big variances. Sometimes month to month you can have a big variance, and what you may find, for example, is there's some explainable cost to it. So, for example, a lot of anti-neoplastic drugs, some of the newer agents can cost upwards of $10,000 and higher per dose. So your anti-neoplastics may be relatively flat month to month, but then you see a big uptake. And what you might find out is it could be one patient having influence on that because they received one of those high-cost products. In other cases, what you might find out is that, there was a keying error made on an order, so you over-purchased on a product. Those things are explainable. Say, hey, you know what? I can send that product back, get my credit. So those things, you want to try to eliminate the things that you can explain right away, and get those off the tables. But then once you kind of explain those things away, then you want to be able to identify, okay, where can I go, and then find savings. So the next step of the plan is to identify your savings. And your basic premise whenever you're looking at savings is you want to make sure first that whatever decisions you're making are based off of efficacy, safety, and then cost. And there's really a couple main buckets that you can look at when you identify your savings. So the cost of a drug is really price times the utilization less your returns, that's your cost. And under the pricing strategies, you have things like looking at your GPO pricing. A lot of hospitals, I would say, rely predominantly on looking at their GPO or their 340B programs to reduce costs. GPOs do offer some significant savings, but for the most part, switching from one GPO to another GPO really probably doesn't yield the cost savings that you think you're going to have. The other thing with COVID, in the days of COVID, if your census is down, some GPOs have special pricing, but it relies on tiers based off of volumes. So if your volumes are going down, your pricing might actually be going up. 340B, excellent opportunity to drive out some savings, but it's important that the program is managed appropriately and that you do have metrics behind that. Usually with the 340B program, you want to have your WAC percentage below 10. You don't necessarily want it at 0 because there is some WAC pricing. That is good. But the other thing, too, is you want to make sure that you're monitoring your compliance. If you're not compliant, you could be kicked out of the program or suspended from the program. At our institutions, we do mandatory audits, and what we typically find out is that when we do acquire an account, most accounts have about a 72% compliance rate, which means that there is exposure at the institution. So you do want to be monitoring your compliance. After that, other price strategies are your formulary management, trying to restrict your formulary, special contracts, and looking at inventory. And I mentioned before, inventory is typically a tactic many pharmacists with immature programs go to because it's easy to do. You just burn off the inventory and you're good. But once again, those savings are short-lived. Your biggest dollars are typically going to be in utilization management programs. And this means putting in evidence-based medicine protocols, prescribing protocols for physicians, and then having a robust clinical pharmacy intervention program. There are challenges, though, with implementing these types of programs. The first is, in order to be able to do this, you have to have both your technicians and your pharmacists practicing at the top of their license. The technicians have to be making sure that the pharmacy is distributing drugs as efficiently as possible to be able to free up the time to get the pharmacists on the floors to work with the doctors. The other thing is that many pharmacists don't feel comfortable having discussions with physicians about alternative therapeutics. And in that case, you need to have some good training programs behind it. So, like I said, even though there's a lot of yield on here, it's easier said than done, so you do need to have those other two pieces of the puzzle in place. And then the last part on here is looking to make sure that you have a good returns management program. There's a lot of programs where you can get credit from reverse distributors. The criteria become tighter and tighter, so it's important that you keep up with that. Not a lot of dollars here, but it is a basic building block that should be managed. And then the other one is looking at controlling waste. A lot of your waste is going to be in your sterile products in there, and there are some opportunities to be able to look at your anti-neoplastics, to be able to look at dose rounding where appropriate, because that can have significant yields. So those are the primary buckets where you can save money. So the next thing is now that you know that those are the strategies, what's the particular savings for your institution? A lot of these cost savings strategies, there's a bunch of them out there in the literature. The challenge is having, once again, a system to be continuously on the lookout for these savings opportunities and developing implementation plans to be able to pull them through. At our organization, our clinical team and our directors have compiled a list of 175 plus cost-saving strategies. And the way that we use this list is we will go ahead and we'll look at the purchase data, and once again, kind of ranking top to bottom, looking for the opportunities, and then systematically putting them on a list and setting a target goal for savings opportunities. You need to have a scorecard like this or some other form, because if experience dictates if you don't have a target, then you really don't know whether or not you're making progress. When you are looking for your savings reductions, there's no exact science to this, but typically, most savings, you can have a target anywhere from a 10% reduction up to a 75% reduction based off of how drug products are being used in your facility. Ideally, the other thing that you want to do is once you set that goal, you want that to be in your pharmacist job descriptions to be able to achieve that goal, or your director of pharmacy. That way you've got alignment all the way from the top of the hospital saying, hey, we need pharmacy to reduce drug spend by this amount, all the way down to a department and an individual level. Once you have that, you've got a good sustainable program. Most institutions, have difficulty taking a lot of initiatives on all at one time. So try to limit your list to 5 or 10. Once those are implemented, go ahead and move on to the next step. So talk a little bit about drugs, going to switch and talk to labor. Most hospitals manage their pharmacy labor using productivity indicators. Many of those indicators are going to be based off of drugs, FTEs per dose dispensed. In my experience, that's really not accurate for pharmacy. But there's a lot of stuff that goes in the pharmacy that's not dose related. For example, doing unit inspections, pharmacies are required to do unit inspections. It could take upwards of 30 minutes per medication area to do an inspection, and you could have up to 30 locations in a pharmacy. That doesn't get taken into account for. Doses dispensed also doesn't take into the clinical activities I talk about, which yield great savings, and productivity indicators sometimes can be manipulated. What I would suggest, and one thing to take a look at, is doing a salary market analysis. At Complete RX, we kind of find out that if you're targeting the 50th percentile, for the most part, you should be able to get and sustain talent. There are some caveats to that. So if you are in a large major metropolitan area or a rural facility where there's either competition or there's a lack of resources, you might have to go up to the 75th percentile. But would suggest to you to, on a regular basis, do some salary market analysis. The next thing is to look at your technician to pharmacist ratios. I had talked previously, you want everybody practicing at the top of their license. In a lot of states, the ratio from techs to pharmacists is 2 or maybe slightly higher. But what we often find out is that a lot of hospitals run at a 1-to-1 ratio or a 1.2-to-1 ratio. So there's opportunities there. The other thing is looking at your full-time, part-time, and PRN mix. A lot of hospitals are staffed solely with full-time pharmacists, so that means anytime you got to fill in a slot for somebody, you're going to go into overtime. Whereas if you have a better mix in that, you're not going to incur as much overtime. And then also look at zero-based scheduling. In a lot of systems, especially in places where the pharmacy staff have been there for a while, the schedule, instead of being based off of what work needs to be done, is based off of personal preference. And that's not always best for the pharmacy, so we do recommend that from time to time you do zero-based, look at how you're doing your scheduling. And then the final thing is monitoring your overtime. As a rule of thumb, your overtime shouldn't be any more than 2% of your S&B. However, there is a caveat with that. In the state of COVID right here, those rules kind of go out the door, just because what I talked about before with mandatory furloughs and people having to sit out because they're being quarantined. So we talked a little bit about the cost side. I do want to spend a couple minutes talking about revenues. As I mentioned before, on the inpatient side, really not a lot that you're looking for on revenues, but still on a daily basis, you should have somebody in your pharmacy looking at your revenue reports. And typically what you're looking for here, once again, are big variances. So if you see a significantly high number, what that might indicate is a key punch error in your revenues, where somebody charged in too much. You want to correct those things early. But on the other side of that, you might see things showing up with zero charges. If you have zero charges, that typically means there's something going on in your charge master. So as a rule of thumb, you ought to be looking at your charge master to make sure it's accurate. Would recommend on a quarterly basis. In smaller facilities where you don't have the resources, ideally every 6 months, if not at least once a year, to be able to do that cleanup. The other thing, too, is you want to look at a revenue to reimbursement analysis. The analysis that you're looking at here, the way that this is done is that you'll take a drug, and then you want to look at the visits associated with that drug. And you're not only looking at the charges, but you want to see what you're actually getting reimbursed for that to be able to ascertain whether or not you're making a profit. This analysis, to be able to do this analysis, can be somewhat complex, especially for those that don't have the informatics capability or, ability to kind of generate pivot tables or to do, the data sorting that needs to be done, because there's large sums of data. In this case, we focused on the top 15, and this kind of goes back to that 80-20 rule. Look at like your big drug spend on here and do your analysis. And in this case, what we found is that there was an issue with immunoglobulin reimbursement. There's a variety of reasons for that to happen. It could be something with insurance. It could be with charges. And in some cases, what you find out is because you have physicians that aren't doing it in their office because they're not getting reimbursed, so they might be deferring those patients to the hospital. But it's a good idea to do this because you could be leaving revenues on the table. So in summary, I've kind of given you the basics of a good cost management program. And with that, I'm going to turn it back over to Mark to close us out.
Okay, thank you, Rick. Great job. Just in summary and in closing, I want to just point out, I think something everybody knows, that the pharmacy department is a core function in every hospital. Pharmacy interacts with every doctor, nurse, patient that comes to the hospital, and the pharmacy department has a huge impact on not only patient care and outcomes, but as the number 2 departmental expense in every hospital, it has a huge impact on hospital financial results. So as we summarize, I think Rick's pointed out that having a culture of cost management and accountability is crucial. It's really the foundation of a good pharmacy, and that's easy to say and harder to do, but it's important to produce that accountability where we all have skin in the game in terms of success. As he pointed out also, it's important to follow the money, measure what matters, and know what and how to manage, to measure and manage. We all see a lot of different people selling data sets, et cetera. I think it's really important, and this can be very complex. I think it's really important that we sit down and understand what the data means and how translatable it is to results. So I think that's probably one of the keys. And then identify cost-saving strategies and revenue capture strategies that you have the ability to deploy and implement. And then from a staffing model, you want to maximize that. As Rick said, use a zero base, work at your top of license, and really understand your workflow. We see a lot of people throw bodies at problems, and typically that's not the answer. And then, as he said, this is not a one-and-done activity. We have the responsibility, particularly during the COVID-19 crisis, but also every day, to continuously measure review and actively manage your pharmacy's performance. So with that said, we would really like to hear your comments, experiences, and questions. So if you would use the chat area for that, we'll try to field those now.
All right, thank you. I first want to thank Mark and also Rick for the discussion today. We do have a couple of questions. Also want to thank the participants, and in advance of starting questions, just letting you all know that you will receive an email with a link to the recorded webinar. So let me get to the questions here. The first one, and you guys just decide who wants to take it. Our wholesaler agreement is coming up for renewal. So in your experience, do you find any one wholesaler is better than the other?
I think we can both speak to that, but I would say for the most part, the wholesalers are, I would say that there's too much difference in regards to pricing. Based off your local geography, there might be some service issues that are important to you and their ability to service you. But in regards to sort of a cost containment strategy, there might be a little bit there, but it's probably not going to be material.
I agree. If I were going to change wholesalers, it'd probably be based on services provided, and some of them are more geographically penetrated than others. But I mean, you're talking about negative basis points, and not to say that every penny is not important, but you're not going to get a ton out of changing wholesalers.
Okay, all right, thank you. Okay, so back to COVID. So what is your take on the vaccine? There's a whole lot of literature out there, particularly this week. And then how do you see pharmacy being involved once the vaccine is deployed?
That's a really good question. Today I was watching the news. There's, I think it's Madura, is going now into phase 3 trials. So you do see a lot of emphasis on going ahead and getting a vaccine out there. I think the biggest key is, I think eventually we will have a vaccine out there, but the question is, one, getting enough product to vaccinate everybody. But then the thing is, once you have enough product, having enough people out there to administer the vaccinations. In a lot of states, pharmacists can give vaccines. The challenge for pharmacists is that we don't get reimbursed for that, and I think as part of the new HHS bill going up there, that's one thing pharmacy is petitioning for, is to be recognized as healthcare providers to be able to bill for the service. But I would say regardless, if you are in a state where pharmacists can administer vaccines, and that's kind of one of those things we talked about, looking forward, making sure that people have the right credentialing to be able to do that, because hospitals are going to be looked at as places to be able to get vaccinated, and you're going to be having to vaccinate large populations over a small amount of time. So, in addition to nurses and doctors and physicians and that others that can do that, make sure pharmacists fit into that, strategic planning.
I think one more pivotal role that pharmacists can play, and I do think, that there are 3 or 4 companies that are moving into phase 3 pretty quickly. They're predicting that in the next, I think 3 to 6 months, we'll have America will have $300 million or 300 million doses. I think the biggest deal they're having is glass vials, so I think that'll be solved. But the other piece of it is education, and I think the pharmacists really play a pivotal role in education on the importance of being vaccinated, answering questions, et cetera. So I think that pharmacists are typically, more trusted in the community and easily accessed. So I think that's another big role we could play.
Okay, thank you. In terms of key performance indicators for pharmacy, do you have a very specific set that you look at? How do you evaluate that?
Well, with key performance indicators, there's some, I would say there's basic areas you want to look at, but you have to have things that are meaningful to the hospital, and it should be in a balanced scorecard format. So on the finance side, you probably want to look at, one key indicator would be looking at how you're doing with variance to budget for the year, but then also how successful are you in achieving your cost containment activity. So, for example, if you've got a target of 100,000 for the year, or the quarter, how well am I doing on achieving that? On the labor side, you can be looking at your productivity indicators. I talked a little bit about that. I would be looking more, trying to manage your overtime and then just your general labor expense in the department. On the quality side, there's a number of indicators that you can be looking at, and once again, that might be tied to the hospital. So, for example, if a hospital is into leapfrog, there might be an indicator specific to pharmacy on the leapfrog. If customer service is important for a hospital, you might be wanting to look at your HCAP scores in regards to patients, receiving education about their medications. The staffing side, a lot of hospitals have their own scores that they use for measuring employee satisfaction. You probably want to be looking at that. You want to be looking at your voluntary turnover rates. So a variety of metrics, but what I would recommend on there is having something that's aligned with the hospital. So the hospital is aligned with the department, and then those indicators are aligned down to, the individual.
Well, I agree, and I think, the things that we typically look at, there are, you've seen one, but there are some basics that you want to be able to measure and track and respond to data. And if you really think about it, from acquisition to receipt of the drug to your workflow to getting the drug to the patient to your clinical outcomes and the discharge process, it's really pretty measurable, and there are some good statistics out there, and that is what controls your cost. So if you want to look at acquisition costs, whether you're using 340B or as Rick mentioned, the buying programs correctly, or maximize points. You want to look at inventory control. You want to look at waste and pilferage. You want to look at your distribution system. If you have automated dispensing cabinets, you want to look at the metrics within those. How many stockouts you have? Are you carrying the right drugs? Do you have too many drugs in the automated cabinets? And then you want to look at your clinical programs to make sure that you're using the best drug, the most efficacious and safe drug to get the outcomes you want, streamline a formulary, et cetera. So we do look at it as how the drugs flow through the hospital and the outcomes we get from them. And we measure it on, as Rick said, a cost per adjusted patient day, which is very important because that is a gold standard measurement. And I think Winston Churchill. So I think you've got to be true with the data. You got to have a point that you're trying to get to. I think Winston Churchill said, "I don't trust data unless I've had a chance to doctor it." So we don't want to do that.
All right. Thank you again for everyone who participated. This concludes our webinar for today. If you have some questions that you'd like Mark or Rick to address one-on-one, their information is on the screen, so please feel free to reach out to them directly. Thank you all, and stay well. Have a great day.